My name is Heidi Sveistrup. I'm the CEO and Chief Scientific Officer at Briere Research Institute and the Vice President, Research and Academic Affairs at Briere. While we're meeting today on a virtual platform, we pay respect to the Algonquin people, who are the traditional guardians of the land on which we work and live. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and honor their courageous leaders, past, present, and future. We're extremely glad to welcome you to 2 waves of algorithmic accountability for mental health apps. Cet événement, présenté par l'initiative IA et Société, est une collaboration avec le Centre de droit politique et éthique de la santé et le Centre de recherche en droit, technologie et société. Il s'agit du premier événement d'une série de séminaires qui seront présentés par l'Institut de recherche Briere et le Centre de droit politique et éthique de la santé, avec le soutien financier of the Associated Medical Services. Briere is a multi-site academic healthcare organization, including hospitals, long-term care, and transitional care spaces. We have 5 campuses of care that largely support adults in post-stroke or geriatric rehabilitation, or who are considered subacute and may have medically complex needs. We also have one of the nation's largest palliative care units, as well as complex memory programs, and are supported by a 2-site academic family health team. The Briere Research Institute includes over 30 active investigators who focus on applied health and health policy research. Our research goals are to support Briere's clinical and residential priorities and to improve our health system through research and innovation. Without further ado, I will hand it over to Professor Florian Martin-Bartheau, University Research Chair in Technology and Society, and an Associate Professor of Law at the University of Ottawa, where he leads the AI and Society Initiative and the University's Center for Law, Technology and Society. Professor.
Merci beaucoup. Bonjour à toutes et à tous. Welcome, everybody. I'm delighted to welcome you for today's virtual talk, where we will be joined by Frank Pasquale, Emmanuelle Bernheim, to discuss AI, algorithmic accountability, and mental health apps. He doesn't need a long presentation, but I will still introduce him. So our keynote speaker, featured speaker for today is Frank Pasquale, who is an expert on the law of AI, algorithm, and machine learning. He is a professor of law at Brooklyn Law School, a visiting scholar at the AI Law Institute, and an affiliate fellow at the Yale University Information Society Project. Is also he has authored many books, including his latest one, The New Laws of Robotics, that I highly recommend. After his presentation, you will hear from Emmanuelle Bernheim, who is a full professor in the civil law section at the Faculty of Law at the University of Ottawa, where she holds the Canada Research Chair in Mental Health and Access to Justice. And she will offer some thought and comments on those issues. And then, as always, we will open the floor to a Q&A session. So we invite you to ask your question in the chat function. And the Q&A part will be facilitated by Michael Da Silva, who is the Alex Trebek postdoctoral fellow in AI and healthcare, and the research associate of the CHR-funded Machine ND research team at the University of Ottawa. Without further ado, I will hand it over to Professor Pasquale for his presentation.
Great, thank you so much. And I just am waiting for my slides appear. I'll
yes.
see those, then I'll take control and put them as the team's language puts it, to take control of the slides and move forward. So yeah, excellent, great, thank you. Thanks so much for these very kind introductions, and it's a real pleasure to be here and to discuss some of these ideas about mental health apps that I've been developing out of the new laws of robotics, and some of my work on healthcare in general and on AI. And to introduce the why I'm interested in the topic and how I got into it, there's a few layers here. One is that I've been writing about law and technology for some time, and was writing about AI, I suppose, when it was being called predictive analytics or big data or all these other terms that were used almost interchangeably in the past. And I've been watching the evolution, into the more contemporary forms of machine learning, reinforcement learning, other forms of AI. And what I find really interesting here is the connection between that work that I've been doing and also work on healthcare finance. And I consider one of the things that I try to do in the US discourse on healthcare finance is to bring in a political economy perspective, and particularly to try to bring to the US, which often has a pretty parochial US-centered approach to healthcare finance, an awareness of just what an outlier our system is, and of some of the economic and other pressures that are put on healthcare providers by the large role of private insurers and others in the US system. And to me, and a final layer of this, what I'm bringing to the table in this project, is a series of works I did on the bioethics of mental health care in the mid-2000s, which were essentially looking at how the definition of mental health can be changed and can be altered by a larger political economic landscape. And so I think if we put together these three layers, sort of a law and technology layer, a healthcare finance layer, and finally a layer of the bioethics involved in the definitions of mental health, all of those I think combine to raise some significant concerns about whether mental health apps of the future will be accountable and fully accountable to pluralistic cultural conceptions of mental health and proper care, or if they will be somewhat Procrusteanly put into the box of disruptive innovation and cost minimization. And so with that set up, I'll move into the slides. One of the things I think is so fascinating here in terms of mental health care is the appification of mental health care. Certainly Nicholas Kateri, a professor at Indiana University, has talked a lot about appification as part of a new iron triangle of healthcare. What we see with appification, I think, is a real proliferation of health apps online, but often without sufficient vetting or certification. There's sort of a Wild West atmosphere out there. And even though large platforms like Apple and Google have been taking 30% of app revenue as just for their gatekeeper role in terms of situating and organizing the apps on the App Store, a really remarkable figure and one that has come to the attention of antitrust authorities around the world. They have not done terribly much, I think, to do enough to protect consumers and to properly define metrics of validation and other ways of thinking about these apps. One reason for that is perhaps because the platform companies and other surveillance capitalists are very committed to using their own devices and monitoring as potential data. So for example, Apple is increasingly interested in diagnosing mental health and anxiety via smartphone behavior patterns. But there's also, I think, got to be a frank recognition that there's growing demand because of cost and convenience concerns, right? In growing fears that essentially there are not enough mental health professionals to treat everyone. And of course, COVID adds a whole another dimension to this because of the emphasis on not going in person. And so certainly you've seen the rise of teletherapy, telepsychiatry, telehealth apps in that respect. But what I'm mainly focused on today is really thinking about the prospects for total disintermediation of the human and purely AI ML-driven apps. And that's what I'll really be focusing on for the rest of the talk today. Now, this is something that has come to the concern and the interest of the US Food and Drug Administration, right? There have been many reports with respect to digital health innovation and how the software could be regulated. I'll just drop in one slide, to sort of give a sense of the exact type of boundaries that are drawn under the current US legal regime, which is where I have, some degree of experience, which is that we see with respect to FDA and the regulation of software generally, in these yellow boxes, there are things that the FDA can regulate, but excluded from regulation is explainable software that makes recommendations to healthcare professionals, or at least that's the perspective that Barbara Evans and I are drawing on in our recent work, Product Liability Suits for FDA-Regulated AI and ML Software. And if we look at these sort of distinctions, in terms of thinking about what the FDA can regulate, what I find so fascinating is that sort of middle box of non-explainable software that makes recommendations to healthcare professionals, or and software that acquires, processes, and analyzes signals from diagnostic devices. I think each of those are going to lead to some very difficult questions for health professionals in the future in terms of the degree to which a handoff is seen as appropriate and wise to different digital technologies, or the degree to which digital technology is always seen as something like a prescription, something that is prescribed by a doctor, but always there has to be that mediation between a competent human professional and the app or other medical technology. Some of my themes today in developing this idea is that there's an algorithmic accountability movement in medicine that's critiquing and starting to address the biases and other problems that afflict computationally inflected diagnosis and care. And I think that movement is going to be very important as we think about the future of AI in mental health apps, particularly ensuring that there are adequate representation of all potential users of apps, that whether these apps are in a complementary or substitutive role with respect to therapists. Now, while the first wave of algorithmic accountability focuses on improving existing systems, a second wave of research has asked whether they should be used at all, and if so, who is to govern them. Right. And this second wave concern is something that I think is really gathering, just gathering now, I should say. The first wave has a lot of people are interested in it, and there's a lot of support, I think, both in medical and legal academic communities and among foundations to help promote it. But the second wave sometimes asks some thornier questions because rather than presenting itself or presenting critics of the AI as people dedicated to improving it, it is instead presented as something that might limit the application of AI in given situations. So that's going to be some of the areas where we might think about to what extent might there be an excess emphasis on automation in mental health care, and we'll get to that in a bit. These questions will become increasingly important as chatbot therapists, symptom checkers, and self-reporting tools become more common in mental health care. Certainly, there's a lot of budget pressure and economic pressure to replace somewhat expensive human beings with apps. And as we see more and more of these tools taking on larger roles, both first and second wave concerns about their validity, about non-bias, and about the limits of automation are going to come to the fore. I think that malpractice and institutional liability law, as well as reimbursement policies, may increasingly reflect these concerns about accountable algorithms. So my main argument here is that essentially, if we take seriously some of the ethical and legal concerns I'm going to be bringing up in the rest of the talk, we have to ensure that reimbursement policy and also even malpractice liability law are going to reflect those concerns, because without those types of breaks, I think it's quite likely that a disruptive mode of medical care will lead to excess defective automation that we could prevent. Now, in terms of classification of mental health apps, one thing that I find quite useful is distinguishing between those that are complementary and substitutive. Right? Complementary ones are devised to complement an existing therapeutic relationship. Substitutive ones are meant to be the therapeutic relationship. So we might have complementary apps that are directed either to the provider. They're sort of part of what the provider's toolkit that might be ranging from diagnostic to checks for drug-drug interactions, to other sorts of applications there, and some that are directed to the patient. So an example of something complementary and directed to the patient might be an app that would be used to report to a counselor or be used to for the patient to input data about, and let's say it's a situation of opioid use disorder or substance use disorder, where someone could input information about cravings, about what seems to accompany those cravings, about potential interactions with the substance that had been abused or the opioids, et cetera. And these types of, there's one app called Reset that has been prescribed in that capacity as sort of a data collection app. But you always see also in this realm efforts, either plans or proposals by VCs and by innovators at the cutting edge in AI and healthcare to try to expand a bit beyond that, right? To say we're not merely data entry, but we're also going to give, say, some guidance or nudges or whatever it might be. Right, and I think that also a final category I would say is systemic, sort of part of an enterprise delivering healthcare, and there I might include triage tools, right? Or you might imagine that within a hospital there can be facial recognition for depression diagnoses, or at least assistance to depression diagnoses. Just as now there are sometimes somewhat crude tests where that might ask persons a number of questions and say that if they've answered yes to a certain number of them, they are likely to have depression. We can easily imagine added to this repertoire facial recognition that could be based on data sets of the faces of those who have been certified, diagnosed as depressed, comparing it to current patients. Now, a first step toward categorizing concerns about therapy apps, I would say, is you'd include things like privacy, representativeness of interactions and advice, and data security, safety, and effectiveness, right? So with respect to privacy, a lot of these apps may be taking in a lot of data about individuals, and we might wonder, is there proper notice and consent there? Was there unfair or deceptive data collection, analysis, and use? Are there use restrictions on the data that's collected? All of those are critical first wave algorithmic accountability concerns. Another set of issues is representativeness of interactions and advice. Is the bot capable of reaching a broad spectrum of potential users? This type of question has already been brought up with respect to physical healthcare by Caroline Criado Perez in her great book, Invisible Woman, talking a lot about how there's a failure to include adequate representation of women's symptoms or of women's other data about women in the healthcare system. There's also articles that I've discussed in my 2019 piece in the Columbia Law Review called Data Informed Duties for AI Development, which were dermatologists worried about failures to have representative skin in data sets that is sort of being used to diagnose melanoma. And I think the same type of current concerns would also apply to voice interactions with these types of apps. To what extent can they recognize different accents? To what extent can they recognize different ways of speaking? All of those are the representativeness concerns are very important. And then finally, data security, safety, and effectiveness means that we might need to have mandatory reporting issues. This is sort of the flip side of privacy, right? You know, I think it's quite fascinating, right? If we think about there are some laws that require that there be very important secrecy protections for the data of the individual. But then there are also sometimes issues where we're insisting upon that there be mandatory reporting. For example, of a mention of child abuse or a mention of an immediate plan to harm another person. So balancing those things is very important, but some initial studies of mental health apps have found that there have been real failures there. You know, that they've failed to, when tested with things like information that clearly disclosed an intent to harm another person immediately, that there was no provision for mandatory reporting. So I think that these sorts of data sharing and gathering standards, and also with respect to effectiveness, all of those are first wave concerns. And just to put very quickly, the physical health parallel that I discuss in my Columbia Law Review article book is this idea of a failure to detect a malignancy from a minority group within a society that could have been detected had there been proper inclusion of that minority group's data in the relevant data set. I think it's something we have to think ahead on, and I think there are clear analogs in the mental health context. Now, fortunately, there are institutions devoted to promoting inclusive databases that include NIST, the U.S. Department of Health and Human Services, and I think that, you know, to the same extent that we had authorized testing and certification bodies or ATCBs for electronic health records, we'd want to see something similar with respect to mental health apps. I also want to raise though, and I realize that I don't want to take too much time on them, but I think there'll be lots of interest in the discussion, I hope, Second wave algorithmic accountability concerns, right? We've gone through the first wave concerns. What about the second wave? Some of those include the political economy of substitutive automation, right? What's going on when, for example, there are high-level officials in charge of healthcare funding who see the app as a potential cheap replacement for human therapists, right? Is that something to worry about? Is it time to worry about it now or not? The second is behaviorist assumptions about the nature of the relationship between the app and the patient or user. This goes back to classic disputes between, say, advocates of talk therapy or more psychoanalytic approaches versus those who have a heavier emphasis on psychopharmaceuticals or on cognitive behavioral therapy or CBT. The worry I have there is that I do not think that it is correct for technology to put a thumb on the scale in favor of one side or the other, right? But I think, unfortunately, thanks to the business models and current sort of engineering mindset of many behind mental health apps, it's all too likely that there will be thumbs put on the scale in favor of more behavioristic models of the interaction between therapist and patient. And that's something I'm going to just speak briefly about in my final or next few slides. And finally, the commercial models, assumed audience, and stakeholders, which I'll get into in a bit. So one of the things I think is fascinating with respect to mental health apps is if we are to, how do we think about an app where there's no human intervention, but the app itself refers to itself as a person or something that needs to be treated like a person? Here we have Wobot saying something along the lines of, someone called me a bad robot the other day, it made me sad. And the expected response is something of empathy, right? But do I really believe that the Wobot felt sad? No, I don't, right? And I mean, part of this is work that I presented at We Robot recently. Emmanuelle Bernheim, Jelle van Dijk, and I have a paper called Against Robot Rights. We're discussing debunking robot rights, metaphysically, ethically, and legally. But to me, I mean, I just, in my last chapter of New Laws of Robotics, I discussed that the robot does not have feelings, or to any extent that can be described as having feelings, they're not feelings in the way that we have them. And so to me, this strikes me as fundamentally deceptive. But even worse, as part of a larger program of using this deception about mental states of a robot or of an AI to gain patterns of trust and access to interior thoughts that someone really, had they thought it through in a more comprehensive manner, would not want to give, right? So that's one of the issues I think is really critical here. If you look at Misty Yang's work on chatbots and public capacities, one of the things that she also discusses is the relationship between painful conversations, automated discourse, and public action. And she worries that AI essentially, because many of the conversations with the AI apps are on rails, or there's sort of multiple choice, or there's only a few things you can choose to sort of interact with them, that this helps erode capacities for contextualizing, norm building, and caring that are part of more difficult conversations and efforts at articulacy. And here, you know, my attachment to an ethics of articulacy really is rooted in my engagement with the work of Charles Taylor. And I think that Charles Taylor's works on sort of the importance of language in constituting identity are quite critical for larger policy evaluation of the degree to which mental health apps should be either trying to cut short or to accelerate these forms of self-articulation and self-understanding, or should they be set in a more complementary role so that those forms of articulacy and self-articulation can be explored with a person, where I think is very important to them. I'll also note that what I find so fascinating in terms of the politics of mental health expertise is that in the book Saving Talk Therapy, Enrico Nalati talks a great deal about the push by insurance companies to restrict access to talk therapy and to promote the use of psychopharmaceuticals as a cheaper road to health. And certainly I am not trying to criticize psychopharmaceuticals in any way. I think that they have a very important place in mental health care, of course. However, I think that when you add in an economic model that pushes in a certain direction, we can again have this thumb on the scale effect, where I think that one of my other principles in New Laws of Robotics is to protect the independence of professionals in these contexts, right? That I think one of the most important things about the professional role is that you have a self-organization that is beyond market and state, that is able to set certain terms and standards of independent judgment. And I think preserving the role of therapists to do so is really critical, just as we preserve that independent role in other professions. I'll also note that, sometimes I do worry about taking a culturally parochial perspective. And there's a book, with a very unfortunate title called Crazy Like Us, but which I think is really a profound inquiry into the so-called Americanization of mental health problems around the world. And this book, I think, prompted me to look at whether in other countries there might be similar issues that I'm raising. And I think certainly in Li Zhang's book, Anxious China, what's so fascinating about this book to me is that exactly, or very similar forms of economic pressures toward redefining the therapeutic relationship have also been noted by analysts in China. And so I think that this problem is not one that's just one of the outlier, bizarrely profit-oriented, market-oriented U.S. healthcare system, but is one that, at least in China, therapists and others have observed a certain push to define mental health issues in a certain way. Now, I see that I'm out of time, so what I want to do is I will skip these technical slides, which are on reinforcement learning, and I'll just go to these rival narratives of digitization, which I think are really help encapsulate the second wave concerns that I've talked about, and then I'll just quickly go through some policy and law that might be responsive. So I think the rival narratives of digitization, here I try to develop a sort of dialogue or debate style of presenting narratives in the same way that I do in my Two Narratives of Platform Capitalism article. Here I think that there's one narrative of mental health apps, calling them a form of emancipation via personalization. So if we just had enough data from enough persons using mental health apps, we could find the optimal interactions between the app and persons to maximize some output, say a self-reported feeling of well-being on a Likert scale, right? And certainly that's envisioned in a more fanciful way in the movie Her, the app there being sort of not merely therapeutic with respect to those who used it, but even taking on far more intimate roles, right? But I think that the classic Habermasian critique of the colonization of the life world is still alive here, because so much of the activity here is market generated and not necessarily generated from within professional communities. But I do think there's lots of promise for very important advances in mental health apps generated more from within professional communities, where they take on a more complementary role. I also think that the concentration, condensation of expertise within apps, often within either startups or later bought by large tech firms, that may be a good thing, but only to the extent it doesn't lead to the displacement and de-skilling of professionals. The complementarity of the app and professional, therefore, is something to preserve, as opposed to permitting the replacement of the professional by the app. And metrics-driven efficiency is always something that can turn into behavioristic conditioning. So with that, I'll quickly say that policy and law are key, that we can push the levers on our reimbursement policy, our licensure policy, on health spending caps, malpractice law, contract in terms of service. All of these, there are opportunities to alter the rules to help avoid the negative outcomes that I've discussed, both in terms of first and second waves of algorithmic accountability. And I know I've gone over. I want to have plenty of time for comments and the common questions. And so therefore, I'll sign out now, but I'm happy to go into more detail on a couple of slides I have left on some of either the technical and legal aspects of the issue. So thanks very much.
So I guess it's my turn. Yeah. So thank you for the presentation. I think there's a lot to say here. Of course, I want to put my comments in context by saying that I work on specific practices in psychiatry that are coercive, and my concern are on rights issues related to these practices. So this will be what I will talk about. And I think we have to have in mind that the use of involuntary admission and forced care in Europe and in North America increases continuously since the past 20 years. And I think there's a link that we can make here with that kind of practices and the use, or maybe the use that we can do with that kind of happen. This is what I will talk about. And of course, these decisions are made in the best interest of the people, but we know that they affect mostly people who live in poverty, who have low education, who are socially isolated, and who are racialized. So this is a point I think we have to keep in mind. So I will develop my comment around two interconnected points that you already raised in your presentation. So at first, in the context where there's not enough caregivers to treat everybody, my first comment is about how the use of the app will affect people access to services differently according to the resource they have. And I think that's something that we already see, but maybe the app will be something that will increase that problem. And my second point is about how the app can be used to make treatment decisions. So you already talked about this a little bit, but I think we can figure a potential link between the app and the use of coercive practices and coercive decision. So at first, the question of the risk that app will replace human therapy is for me directly linked to equality in mental health care. And this is something that we already talk a lot about, of course. So it's a problem that exists already. And we see that the resources in terms of money, of course, but also in terms of social and cultural capital have a huge impact of the kind of services people can get. And if people can manage their crisis in their own support system with paired caregivers, it will make all the difference. And that's something psychiatrists confirm a lot. And they said if people have loved one or people they have around them, or they can pay for caregiver services at home, they will not be involuntarily admitted. So that make a big difference, of course. So the people that are socially isolated and who don't have the financial resources to access to the service they need, and in particular therapy. So you talk a little bit about this, and I think this is something that is really important because therapy is not accessible for everybody. So they depend on public services. And now, and it worse with COVID, of course, the public system is so overwhelmed that the wait time to see a psychiatrist is several months, and they are not always able to follow up after that. So with such long waiting times, there is possibility that the app will be used to replace appointment, to replace follow-up caregivers. And we will come to accept the lack of services for people who cannot afford to pay for them, for that kind of services, for the service in person, in fact. While at the same time, of course, people that can afford that in-person services will continue to do so. So I think the real risk that app could replace human therapeutic relationship is not for everybody. It's really for the people who are dependent on the public system. So the question that it raised for me is what kind of use will be made of the information collected by the apps, knowing that these people are more often subject to coercive practice. So the app, of course, can be a tool that keep communication going between professionals and patient, and can be increasing a good communication, of course. And what will happen when the follow-up can be done, and more particularly, I think about medication, which is a big concern in psychiatry. So it can be a great tool for monitoring, collecting information that patients maybe don't want to share with their professionals. So we might think that people can simply decide to do not use apps, but this is not taking, I think, in account the power dynamics in the therapeutic relationship in psychiatry. And the fact that maybe refusing to use an app can in itself constitute an information. for the professional. For example, in Ontario, the physician who had a reason to believe that the patient on a community treatment order is not taking their medication can admit the patient under hospital involuntary admission. So in this context, refusing to use the app can certainly be a reason to believe that this person don't want to take this treatment and led to an involuntary admission, of course. So in mental health right now, in the public system, medication is often the only service that we can offer to patients. So for me, the risk that the app will be used to collect information in addition to other measures, such as injected medication or community treatment orders, seems very real. So this was my comment. Thank you.
Okay, thank you both for your, first, Professor Pasquale, for your talk, and Professor Bernheim for your commentary. I'm just going to remind us all that you can pose questions in the chat, which I will be happy to wield. Before I do that, since nobody's been quick enough on the typing, Professor Pasquale, would you just like to spend a minute or two responding to the commentary just given?
Yes, these are really important comments, and thank you so much to Professor Bernheim for these really terrific comments, because they add a whole nother layer of ethical concern that to me is, and that's why it's so great to do academic presentations, you know, to hear, like, it's far more urgent. The issues that you're describing are really urgent in terms of thinking about the potential, both the potential good that the apps can do, you know, in terms of underserved populations, but also the coercive implications here, right? That there are some really potentially coercive issues here. And I had not thought about the power dynamics in the relationship where the potential is for a patient either to use the app or to be involuntarily committed, right? And I think that that is something that, you know, we are having a really interesting conversation now over e-carceration. You know, is that there is a lot of concern about, I mean, the U.S. prison system is sort of a global outlier in terms of both its extent and its brutality. And there's lots of people saying, well, we need to create something that is not as harsh as the actually jailing people. And what's been proposed is, it started with ankle monitors. And, you know, when I used to work in Baltimore, I would walk to work, you know, a half hour, and I would see many people with large black boxes attached to their ankles, especially in summer when people were wearing shorts. And, you know, I just found this, on the one hand, almost anyone would rather choose to be wearing a black box on their ankle than being in a U.S. prison. But on the other hand, it just struck me as an incredibly stigmatizing and burdensome thing to experience. And, you know, and now people say, well, now the advocates for incarceration say, well, we're going to just put it on people's phones, so no one would even notice it. But that to me is, you know, with the same hand that seems to be giving people, it also is making it a lot easier. It's making it a lot more acceptable and sort of working it into the background. And, you know, and to think about the insistency of notifications and of location tracking and all these other things that are sort of affordances of the contemporary phone, it worries me a lot. And I think that there was a article from about 10 years ago, I think now, called The Right to be Unnetworked. And it was an article by someone that wanted to be essentially establish that if banks used your online activity to decide to give you a loan or not, that you have the right to a credit score that was not predicated on your online activity. And I think this is a really interesting idea that, you know, that one would have a right to an evaluation not based on the app-driven data. And there was a recent European case, I think, about the Finnish data protection organization, where there was someone who complained about being denied credit and said, you know, I think the algorithm is fundamentally biased against me. And I believe that I don't know if the case itself ordered this, but it certainly was in the realm of contemplation that a remedy for this person would be to give them a personalized assessment as opposed to an app assessment. So that, I think, is really critical. I also think that your definition, the distinction between persons who would really be at risk of this being in the public system versus those who can afford to be outside it, really rang true to me. Back when I was doing more work in healthcare finance, I remember being very interested in the Truly decision. I'm sure I'm mispronouncing it, but Chauili in Canada, which I think established something like a constitutional right to an alternative or to the private insurance. But I don't quite remember the exact details. But I think that that issue of having alternative systems is a very interesting one, and one that especially for someone like me, ostensibly coming from a law and political economy perspective, I should be sensitive to this idea of the tiers, of the tiered effect, and having some people on a certain tier of wealth and connections are not going to be worried about this at all, or not really go, and it's going to be a free choice, versus others for whom it is not. And the last point I'll make, in the issue of like 5 to 6 months for psychiatrists, that is a huge problem. Yeah, and I think that this. And I think that in the English and the British context, Jeremy Hunt, when he was the Secretary of the National Health Service at NHS, at one point, when there was the junior doctors strike, said to parents, look, nowadays we have Google. If your child has a rash, take a picture and you do a reverse image search on Google, and you'll see like if the rash is serious or not. And this was a terrible thing to say, because there are lots of nurses immediately went on Twitter and said, here are 2 rashes. They look almost identical, but one is life-threatening and one is a diaper rash. And that to me is a similar risk, I think, is at stake if we have cost cutters at the head of public health services who say, look, I mean, we have Wobot. Why do you need to see a therapist? Or another thing that I really worry about is step-up therapy. Like with some cancer treatments, they might say to people, well, you don't get the most advanced monoclonal antibodies. You need to first use the first round of chemotherapy. But the worry becomes, if there's not, it may well be that is the standard of care. But on the other hand, I worry eventually we're going to find out that there are step-up therapies you're required to take that are actually destructive or harmful. Like there's so many side effects of certain older forms of chemotherapy. And to me, if the apps have a step-up role, where the government says, well, you need to do four months of Wobot before you get access to a psychiatrist. That to me also strikes me as in its own way being coercive, and there's a coercive potential there. So these very rich comments have really opened up my the sense of that I have that there are so many different issues here that I think could really bring the point home more effectively and about a more vulnerable population. So thank you.
Yeah, actually, the point you make about the distributional elements and issues on access to care actually dovetails well with Colleen Flood's question. And Colleen raises a variety of data about the maldistribution of mental health in Canada in particular. She notes that there's 62.7 psychiatrists per 100,000 people in Toronto, but just 7.2 per 100,000 residents in rural areas. And then notes that 10% of doctors in Ontario see less than 40% of patients per annum. So she raises these points, and then she raises another question that is related to it, which is mainly, does starting with an assumption that these apps are going to be problematic perhaps lead us to miss some of these positive potentials? And she puts it in another way. She effectively says, well, aren't we being a little overly romantic about how good care is right now? And if we go in with this romantic view, isn't there a worry that this will undermine our ability to improve care for people who have been unable to access it in the past?
Excellent questions, and and I think that by the way, I'll apologize in advance because my chat is not working. I think I did not update Teams before properly, but I really appreciate your description of the question, Michael. And so I will just sort of going through the issues raised there. Let me start with better than nothing, because I think that's a classic sort of issue with respect to critiques of AI. And it's an important critique, saying, if someone has no access, certainly the app has to be better than nothing. The only counter that I'll just say for now is I'm broadly in agreement with that. I did go to a presentation by Laurie Andrews at a conference on AI in healthcare, probably 3 or 4 years ago now, where she described some of the really unregulated apps that are out there on the App Store. One of them was ostensibly for bipolar disorder, And it advised persons who are on the manic side of the bipolar disorder, between manic and depressive, they were manic. It would say, oh, maybe you want to go and have some beers or drink in order to feel better, or to be chill out a bit or something, right? And that clearly, and at least that probably is not as contraindicated, on many levels, So I think that there are apps out there that are actually like giving pretty reckless advice. And my worry is that if you combine that with U.S. First Amendment jurisprudence, that they might assert the right to be able to say whatever they want if they're not holding themselves out strictly as a therapist, but just say, well, here's something that's a general health and wellness app, which is a gap in FDA regulation. They regulate the medical apps, but not necessarily general health and wellness. That to me is a real problem. I will say that with respect to, but now let's set that aside, because that's an outlier. I'll admit that's a complete outlier in terms of like giving, potentially some really troubling advice to an individual. Let's say that the app does give, is relatively well certified, et cetera. I think that the only worry that I have is the worry that comes out of the disruption literature and business by Clayton Christensen and others. So the disruptive literature essentially says that you start with something that is just good enough, and then you later get to the point that just good enough becomes the only thing available, right? That to me is one of the things that's quite possible here. And the example they give is what Clayton Christensen gives in Innovator's Dilemma in the business book, is the move from really high quality cameras to disposable cameras, right? And the disposable cameras, before cell phones, which were the ultimate disruptive app for disruption of cameras. But it's a dated work, as I'm showing. But we used to have these we still have these more mechanistic cameras, and then there was a preference for, say, disposable ones, et cetera. And I think that is my the only counter, or one counter, that I would give to the idea of not over romanticizing it, because I think it's, once something gets deemed care, it's too easy for that simulacrum of care to become the substitute for the real thing. And I'd also say that, like, within education, there's some really interesting debates about this now too, right? And it's something that we've all had personal experience of, probably, of remote classes during COVID, right? And for some time, I mean, the higher ed discourse that I discussed in chapter 3 of the New Laws of Robotics book, the higher ed discourse was saying something along the lines that the future is online only, that we need to move as many people as possible to massive open online courses that will maybe spend $10 million on a course, but will have 10 million students. And so they're each going to get they could each pay $1 a piece for the course, and we cover the costs. And that's going to solve our higher education cost problems. And that's going to be great. And I think those of us within education, even before we experienced the deficiencies of the COVID all online situation, we did have a sense that, like, this was a problem, that was not going to go as well to have a class, say, on torts that was taught by one celebrity professor to 10 million people, as, for example, to have a lecture with Socratic method, or ideally, my ideal educational setting is, the seminar or the smaller class of like 20 or so students, where you have an open discussion and you can continually in person be monitoring the body language and facial expressions and others in the room to have a sense of what's working, what's not, who's perplexed, who is not, et cetera. And I think that, one of the reasons why the New Laws of Robotics book covers a wide array of professions is because what I'm trying to do in it is, I feel like a lot of the readers will have firsthand experience of one of those professions. I have firsthand experience as a lawyer and as a professor, as an educator. And from that, your firsthand experience of the deficiencies of the AI replacements of yourself, you can empathize more with the people like Enrico Nalati, who I quoted in the talk, the advocate of talk therapy, who has concerns about the impact of substitutive apps. So that would just be my idea there. Is that I don't want to, but I do think that there's going to be a really interesting tension between the short-term emphasis on making sure that we actually do as well as possible in these better than nothing situations for individuals, and the long-term worry that the more we emphasize and lean on the automated care to substitute for therapy, for in-person therapy, the more that we risk the possibility of just losing that as an art, or just entirely eroding it so that it's like just the province of the very wealthy. So yeah.
Yeah, that's very interesting. There's a lot to build off of there. One thing that I'll just note from the chat is that Abigail Brocious notes that one further challenge in this area is a lack of infrastructure in rural areas could undermine the ability for mental health applications and other online tools to serve as this remedial function that we're discussing. I mean, if we look at it at a global perspective too, I mean, I would add that there's a sense in which it might be easier, even notwithstanding concerns about infrastructure, to be able to access a cell phone than be able to access a particular human care. That's true in Canada. That's also true in a more global level as well. So there's a lot of complications here. One other complication I'd just put on the table is that you note that when we start to call something care, when it's really just a simulacrum, there's a real loss there. One thing, though, I just want to highlight is that there might also be a gain, which is then it becomes a lot easier to regulate. So you are pointing out this real problem that we have, that a lot of things fall under a broad variety of exclusions. But there might be strategically something to be said for saying, look, these things are serving a function of care, and thus they fall easily within our jurisdictional competence. What we need to realize is that some of this is snake oil, and really have good regulation and say, yeah, it's care in a sense of which it's trying to do care-like things, but it's not doing it well. And that might be a reason to say, from a legal perspective, we're going to call this care, but from a humanities perspective, we're not. I was going to ask another question, but I wonder if you have a reflection on that first.
That's a great point. Excellent point. And I think that, it is something where another version here is to think about levels of care, sort of like a tiered licensure system. So for example, in many states, we have the issue of licensure for doctors, licensure for nurses, licensure for respiratory therapists, for other forms of care, nurse practitioners. There's a whole number of tiers. The legal profession is pretty late to this. In the state of Washington, there's now something called a legal technician license. So it's someone that doesn't necessarily have to go to all the years of law school, but then may be able to do certain things, in terms of helping individuals in their legal problems. And so I think a tiered licensure system might be something that would be helpful here. And it is certainly in tension with my other direction of my talk, which is to be, quite dismissive of the apps and just sort of say to define them out of the care situation. So it's something to think about. It's something I'm going to think deeply about. And it's one where there's a tension between the work that I do in books like Black Box Society, New Laws of Robotics. I try to straddle social theory and law, and sometimes that there's complementarity. But as you're pointing out here, the critical social theory that leads me to be to try to want to draw a very strict line or to make a very clear distinction between a person and a human in these mental health contexts also is something that, when I wear my hat as a lawyer, is something that is going to be problematic to the extent that the predicate for regulatory authority is the definition of the interaction as care. So thanks.
Yeah, so to make things even more complicated and throw a hard one at you, Jennifer Chandler raises these access issues and notes that there's medical assistant for dying is something that is legal here in Canada, and as of March 2023 is actually going to be legal even in cases where the reason for it would solely be mental illness. And so one thing that Jennifer points out rightly is that mental health applications and telemedicine more specifically are offered as an opportunity to address issues with access to mental health care that will minimize the chances that people will use medical aid in dying for purely mental illness where they otherwise would not do so. And so Jennifer's basic question is, she ends up saying something along the lines of, I don't think that apps are going to be a lot of help in this sector, but do you have any thoughts on the role that apps might play in this relationship between difficulties in access and, in particular, their implications for the MAID debate?
Thank you so much, Jennifer. And it's wonderful to be in contact, even if just virtually. I remember going to such a terrific workshop with you in Halifax. I guess it may have been a decade ago or so. And your work on, I remember one of your articles that described people who were suffering pain and then needed to be and were told that to mitigate for mitigation of damages they may have to go under certain procedures. That was something that really influenced me in terms of thinking about autonomy from the law imposing technological solutions on individuals. And so I think that this question is so fascinating because it is a really difficult one, and let me connect it to something that I think that if we worry that there are individuals that are going to be seeking aid in dying because they've gotten no mental health care and that an app may be a lifeline to them, yeah, that does raise the stakes considerably, right? I think that there are also dimensions of your question that sort of were suggesting that there are issues here in thinking about the nature of the mental health care given, and in considering whether there's, to what extent can there be any sort of algorithmic determination of qualification for aid in dying for a purely mental health issue, right? And I think I may have read some of Trudeau Lemon's work on this. I'm not certain, but I was thinking about the sort of comparative, some of the frontiers of aid in dying and some of the most controversial issues involving someone that was a claim for aid in dying based only on depression or similar, or severe mental illness, other forms of severe mental illness. And I think that this is a situation where I'm reminded of the Roberto Simonowski book, The Death Algorithm. And in that book, he's looking, one of the chapters is looking at intensive care units that are increasingly, they have individuals that are close to death, but they do have cardiopulmonary activity that can be kept going by ventilation and pacemakers, et cetera. And even if most of the brain has died, the brain stem is still intact. And so then under the Uniform Determination of Death Act, they're counted as living. And yet, there's people, family members that say we want to stop the ongoing, what they view as prolongation of death. And a lot of times neurologists are just very hesitant to say, well, yeah, there's absolutely no chance of this person ever making a functional recovery, et cetera. And the quantitative answer has been, well, let's use ICU data to project from given data sets of individuals that have died, how close any particular individual is to matching the set of data in the number of patients that have died within 2 weeks. Or you could say 100% of patients who have this set of biological data as monitored by the ICU monitors would die within 2 weeks. And have had no functional recovery. On the one hand, I view that as an extremely important and informative tool to help individuals make what are some very wrenching decisions, about when to terminate treatment in an ICU with someone who is gravely ill or in a persistent vegetative state or whatever it might be. But I also worry that there's a way in which those same guidelines can become guidelines for public health authorities, for insurers, for others. And then once again, when we add in the dimension of the economic pressures experienced, that could lead to a certain level of pressure toward premature decisions. But of course, it's hard to say that exactly because, at least at the present, the decisions don't often seem, by and large, the discourse about these sorts of end-of-life decisions is not that they are premature. But to get back to your point, though, about the assisted suicide, I do have to think a lot more deeply about that question and about the role of apps and both in potentially keeping people from getting to that point, and then also how data from the app might be used in any sort of proceeding that was going to go on that would need documentation to permit the person to carry out their plan. So thanks.
So there's two very interesting questions in the queue, but I'm going to take my chair's prerogative to ask a perhaps naive question first. And it's about the way that the arguments about the waves work. In short, I'm wondering how I'm supposed to characterize these, and then how the way in which you set out the questions that they're answered map onto the issues we relate at each stage. So, I guess my big picture question is, should I understand these analytically? First, we address one, then we address the other. Should I understand them as stages of regulation, or as moral, or is it sociological? Are you just saying, look, this is the way that the conversation has moved, or is it prescriptive? This is the way that the question should move. And then in particular, so once we get that on the table, I'm curious as to how it is that if we're characterizing the waves as the first saying how we reform existing institutions, and the second as addressing whether we should be using these things at all, I'm wondering why it is that privacy, representativeness, and security are wave one questions, and political economy, behavioral assumptions, et cetera, are stage two. And the reason I ask is, it strikes me that privacy, representativeness, and security questions certainly go to whether we should be using these things at all. And in particular, when you talk about how we're going to address these concerns, we get into things like malpractice law and liability issues that seem to me that could be understood as just reforms of our existing institutions, and so be at wave one as they were originally discussed. So I'm just wondering how maybe I'm misunderstanding how the questions were posed in terms of the stages, but if so, it will be edifying perhaps to see how I misunderstood them. So yeah, thanks.
Sure. So, I think that the relatively straightforward answer would be that if we presume that we want to see more substitutive health apps or mental health apps out there, then we're going to be primarily focused on the first wave concerns. I think that the second wave concerns come up in terms of and the irony is that I think the irony here is that the second wave may always be too late, or may be too late because once you've done a lot of first wave work, you have a lot of people that would potentially be the critics that would lead the second wave efforts to ban or severely restrict use of certain algorithms or AI, have been in a way co-opted into the process of improving them, right? Now that's a difficult question, right? And that's something that it's not a comfortable question to pose, because a lot of the leading voices in the field are people that are saying, I'm going to do something that's going to incrementally improve the app so that it is representative enough, so that it has proper data privacy and security, so that it's very unlikely to raise malpractice concerns, et cetera. But I always want to bring in the people that are saying things like, I don't think it should be used at all. Because I think that we are, although we may not be here yet, we're going to see within the next decade types of apps that I think are going to be apps that are just not properly part of a mental health armamentarium under certain theories of personal autonomy and of professional responsibility for care. So that's going to be that'll be my position there. So I think that and when you mentioned also about are they more descriptive or are they more normative in terms of what's going on, I'd say both. They try to fuse the descriptive and the normative, and I think one of the other of the many losing battles, I should say, that I've been fighting in my academic career is a battle on behalf of holism against methodological individualism, and a battle against positivism, because I think that there's a lot of emphasis, especially in the sort of economics and engineering approaches to AI, that really is positivistic and that says that we can strictly separate facts and values. I think it's often very hard to do that, and so I think that part of the wave periodization of concerns is to try to help do that. And the last thing I'll just sort of say to give an example there is. The e-carceration example I gave earlier, I think is really a helpful and illuminating one, because it's a real problem that we all face and we all can viscerally see. And I really appreciated Ruha Benjamin's work, Race After Technology, where instead of trying to figure out what was the most pleasant way to run e-carceration. She just said, these are modern day shackles, and I don't want to have any part of them. Whereas there was an Australian research group that I mentioned in my book that essentially said, hey, if we could have, say, remote incarceration of individuals plus virtual reality, that would be really great. You know, because and I'm saying that, like, and I think a second wave objection may say, no, we don't want to sort of put those together, sort of make those part of the carceral apparatus. And I think that that's where I, unlike a lot of the discourse in AI and law now, I want to see a more assertive role for the regulators to shape the development, as opposed to sort of coming into the back end and trying to fix things once they're out there in the public domain. Thanks.
Well, at the very least, the clarification was certainly edifying. Thank you. That was interesting. So we're getting more comments about access. This seems to be something that I think is crucial to the conversation. So I'm unsurprised that this is where conversations are coming from. Colleen Flood notes that, you know, in terms of access to healthcare right now in Canada, it very much is a province of the wealthy. She does, however, note that, you know, one thing that could happen if we do rely on these things is that we get more care, but it is sort of offloaded onto these apps. So it might be that we get more access, but it's predominantly in terms of access to the applications. But I want to move on to a particular question about access that Bita Amani raises. And I'd like actually both Professor Pasquale and Professor Bernheim to weigh in on this one, which is, in particular, how should we understand the access questions and their relationship to consent, particularly in pediatric contexts. So Professor Amani asks about questions concerning minors, their privacy interests, their consents, the competing interests of parents and children, and asks, how do these relate to questions about access? And further, how should they relate to questions about accountability and governance in the mental health context? So I'll ask Professor Pasquale to talk, and then we'll let him have a breath, and perhaps Professor Bernheim will come in as well.
No, I've been speaking so much. If you don't mind, Emmanuelle, if you want to respond, I could go next, if that would be fine. Yeah,
that'd be great.
Oh, thank you. Well, it's a big question, in fact. I think at first that it have to be understood in the big context of where it's difficult to access to services in psychiatric, pediatric psychiatric services too. And the app maybe will be, and I appreciate what you said, Michael, earlier, when you said maybe we can recognize that it's not real care, but if there's nothing else, it will be better than nothing. So maybe it will not change anything. I'm not sure that law is the solution here. And for minor or for me, for minor, it's as well maybe the same question as for person that are incompetent, you know, and that we see that we can take decision for them and for their best, but without taking account of their own view of their situation. And for me, the app maybe will be a new tool in that kind of dynamic where we can collect a lot of information on the person, what she's doing, what she want to do or not, and how she's doing it, and maybe the behavior she can have that is maybe weird or something like that. And we see that it's a lot linked to things like forced care. And how this will be used by parents that want the best for their child. That's the same thing that for person that are incompetent. And I think there is here maybe a slippery slope where maybe for the best of the person we will substitute ourselves, and the app will be a tool for that. So for me, it's maybe something a little dangerous, and I don't know how we can, be able to know how to put responsibility on professionals and on even on families that will use that kind of tool. So for me, it's really a red light.
I would agree completely. I think that's a very powerful points, and I think that one of the things that is helpful here is to consider some of the case law. And again, I apologize for my somewhat parochial perspective, but I'll talk about some U.S. states which arose or at least arose before, and then was really important with the rise of consumer-directed healthcare. So some of this case law involved, say, the unitary standard of care and the ability of the patient to sign away rights to it. Right? So you can imagine a situation, and this is just, what I'm presenting is just a slight variation on a case called Tunkel versus US, or Tunkel versus Regions of California from 1965 or so. Imagine a situation where someone is told, well, we can give you care that'll be the top level, top rate, most cutting edge, but we'll give it to you much cheaper if we can give you much cheaper care that's not quite at that level. So that's one bargain people could make. And then another bargain people could make is they could say, well, we won't even admit you unless you agree not to sue us for malpractice. And what I think is quite remarkable is that, at least with respect to the medical cases that involve these contracts not to sue, most of these cases, the defendant hospital loses. Essentially, the idea is that you can't foist onto your patients their signing away their right to sue for if something goes awry or goes amiss during their time there. However, if you look at the digital ethics of apps are replete with terms of service where people not merely sign away their right to sue, but indemnify the maker of the app for anything that might go wrong for it. Right. So this, I think, is quite interesting. This gets back to the earlier point, Michael, you made about the issue of calling it care versus not calling it care, and some of the distortions that are arising there. So we move from a realm where your right to recompense is inalienable to a realm where your duty to recompense the other entity is being essentially foisted on you. That's a really big shift. And I think a lot of people don't realize. And to me, that's one aspect of the unfair competitive advantage of the digital, right? And I say this as someone who has criticized the U.S. Federal Trade Commission for intervening in U.S. state proceedings to stop them from stopping apps from imposing on their users these one-sided terms of service where they agree not merely not to sue, but also to indemnify the app. So, I think that the issue of, and then finally, I guess the other access question that I would say is, it is part of what we have to think about is, I want to respect the concerns about access and potential access via AI and apps. But what I also want to characterize this is, it's not only that we are, say that we expand massively the amount of mental health care that is occurring through apps and especially AI-driven apps. We may well be expanding access, but we're also recruiting lots of entities into a longer-term technological transformation of the field, right? Because we sort of, one of the tenors of the talk today, at least in the questions that I feel now, is that there's not going to be any more money for persons to do this, right? That's a fascinating assumption. I don't know if it's necessarily a valid assumption, but I think it kind of is an assumption that, the budget is tight and we're in a time of austerity, or maybe it's always been austerity. I don't know, but and we're never going to have more money to bring more people into the mix and to train them better and to maybe have a vision of complementarity. And I think that part of what my Chapter 7 of New Laws of Robotics does is I try to discuss our assumptions about monetary and fiscal policy that would enable us to open up the conversation a little bit more, and rather than seeing the app as, say, something that deals with bare access concerns or cost concerns, to see AI and robotics as ultimately being something that's going to improve the quality of the care, education, journalism, other industries, right? So that's where I'm trying to shift the conversation. And I think that, I am willing to acknowledge that the short-term effects of my advocacy may well be to reduce the business model and reach of a lot of these apps. But I think that's in the service of a longer-term vision where AI and robotics are complementing human professionals in many lines of human endeavor in a process of continual quality improvement that is really only plausible when that complementarity occurs. Thanks.
All right, so we have about 5 minutes left, and we have two questions. One's a little narrower and one's broader. I'm gonna package them together because I think you can answer the first in the context of the second. So the first question from Tugba Basaran Akmazglu effectively asks about whether there's two kinds of risks that we need to regulate in this area. When it comes to mental health apps, there's Tugba asks, first, is there concern that there will be a level of reluctance or distrust of mental health apps that we need to be alive to, raises questions about the uncanny valley? Or are there related concerns about that these tools might be easier to deceive or mislead than an individual? So these are questions about whether these are things that regulators need to keep in mind. And then Colleen Flood then says, having appreciated your point about positivism, Professor Pasquale, she raised a bigger question that I think you can address that narrower one within, which is, well, let's say that regulators do take account of some of these larger norms and issues and do really regulate in their area. Isn't there still a concern about lobbying, either from innovators who just want innovation for innovation's sake? We get a sort of regulatory capture concern, or from healthcare providers who resist change and really don't want any changes to their practice? And so is there then a concern that even if we can get the regulators really looking at these things, they won't be doing what's in the public interest or the best interest of patients? And so I'll quote her here: how do we get to that magical unicorn that will allow regulation, that will address all these difficult issues we're dealing with in the public interest? So the narrow question and then the broad one that I think is a good place to end on. And Professor Bernheim, maybe I'll ask you again to go first, just because Professor Pasquale could probably use a breath.
Sorry, but can you repeat the first one? I'm
yeah, so the narrower question is, do you have any concerns that people will either trust their AI tools less than they would a human, or try to deceive or be more successful in deceiving their AI tool than a human? And the second one is, how do we make sure that regulators, when they regulate, actually do it in the public interest?
Yeah. For the first one, I think, yeah, it can be a concern. And for me, it raises another question, which is, how do we know that apps themselves will not have a negative impact on mental health of people that's using it? Because we see a lot that people said that the problem for them in mental health services is that they don't have enough good contact with their caregivers. And we saw that, in fact, when we are going to court, for example, to see what are the discussion about, the circumstance of forced care or involuntary admission. People talk about that a lot. They want to have therapy. They want to have contact with people. So I think, yes, maybe for them, and the app will be not something that can replace that kind of contact, that kind of relationship, or what they want in that relationship, and what they expect to have, and what they need, in fact, in kind of therapy. So I think, yes, it's a real question, and I was asking myself, if we have data on this, do we know if app can have that kind of negative impact? And for the other question, I would say, of course, I think that this is a big market, and mental health is a big market at first. So yes, if there's money to do here, I don't think that the best interest of the people will be the first thing that will lead the decision and that we can think, of course, that, and we see it with all the development of medication and things like that, that it's not the best interest of the people that are in the first things we have in mind, and that there's a lot of money to do that, and that at first medication replace relationship with caregivers, and now we can think that HAP will add something on that kind of relationship they already have that will permit to monitor. Does this person take that medication that we want her to take, but with no impact, with no positive impact on maybe therapeutic impact and relationship. So yeah, I don't know if I'm really clear, but and I would appreciate, Frank, if you have that information about the impact of apps on mental health of people, of users, if you can talk about that too. Thank you.
Great, yeah, and this is a really good way to wrap up, both in terms of the question, the narrower question, where I particularly want to address the idea of deception, both in terms of like detecting potential deception of the user and of the user being deceived. But I'll start with the question of, and the regulatory capture issue is important, and I'll get to that in a bit. And then, but just to start with the idea of the effect on individuals. I think that there needs to be a much richer conversation of how we measure effect, right? Because there are studies out there. Now, in my book, I have discussed, and I've cited some meta-analyses of mental health app effectiveness, which were to me pretty unimpressive. And particularly like there was the NHS had, I think, 14 apps in its app library, and I think one study showed that only 1 or 2 had actually been validated with anything sort of that would be ring true with a substantiation of its effectiveness. So that's really worrisome, right? But I don't think that'll be a problem for long. I think it's quite, and in fact, if I think back to my article, Grand Bargains for Big Data, that was my big article about, in part, pharmaceutical companies cooking the books on the effectiveness of drugs. And I think it's quite easy, in fact, even easier for people behind apps to sort of create set up situations where they will seem quite effective. You know, you just sort of there's just so many confounding ways in which, and the assessment of mental health is so ineffable. The same types of things that I think David Healy was trying to blow the whistle on many years ago with respect to failures of Pfizer or whatever the company was behind Prozac to recognize some of its problems and also to acknowledge its very limited effect when compared to placebos or compared to some other drugs. So I think that one of the questions here is, what is the nature of medical policy evaluation here? And I think that's a really interesting one. And part of the question to me is going to be, does it only include, say, avoiding very negative events? Does it involve sort of self-reports of affect on, say, a 0 to 10 scale? Does it involve membership participation in the community in a way that sort of vindicates person's life goals? That's a really great question. And I think that and maybe one of the reasons why I'm so uneasy about the move of Silicon Valley into this space is because I feel that the space itself, in terms of its evaluation literature, is to me insufficiently complex and recognizing of human realities. I'll say just quickly, I realize we're running out of time, so I'll just say quickly with respect to the deception question. It's funny because I think the question was posed as, are you afraid that the people are going to be able to deceive the machine? I think that that's a worry, but I also worry even more about a machine that cannot be deceived, right? I worry more about a machine that is somehow, and the reason I say that is because I worry about the machine itself being a regime of truth production. You know, not to get too Foucauldian, but to sort of see the machine, the app itself as being taken as an authoritative determiner of a person's state of mind or mental health level. And that, I think, is a more profound worry to me than the fact that someone might deceive it. Because I think in looking at the ability of machines or people to detect deception, I don't know of a clear advantage of one side or the other. I will also say, and the last point by Colleen with respect to the question of the capture issue, I really appreciate that. I do sometimes in my darker moments think that, who cares? Because it's like with respect to regulation, because I see what, for example, the FDA did with Aduhelm, this recent Alzheimer's drug that really has almost no proof going for it, and which, because it's been approved and costs so much, has led to a preemptive raise of 14.8% in Medicare Part B premiums in the US, which is just shocking. I mean, it's one of 3 factors leading to this massive hike in premiums for people on Medicare. And so therefore, I don't know. I think that it is a really tough question. And I think that the classic go-to work that I look at when asked about this is the book Preventing Regulatory Capture, which I think is useful in terms of looking at different regimes that have done a lot to try to prevent regulatory capture. I think it's by Dan Carpenter was the editor with a few other co-editors. But I think it's an ongoing concern and something that certainly will be a problem here. So yeah.
All right, so we're just at 1, but I'm going to turn it over to Colleen Flood to add to my thanks. Thank you both, and Colleen, take it away.
Thank you so much. I hope you can all hear me okay. I just wanted to add my voice of thanks to Michael. First of all, Michael, thank you very much for moderating the session. It's most appreciated. And of course, we'd like to thank Bruyere and Heidi for collaborating with us and the funding support from Associated Medical Services. Thank you very much. And to the wonderful Justine, who works with Florian, who helped set up this event. Thank you so much for the AI and Society Plus program for doing that. And last but no means least, of course, thanks to both Emmanuelle as a terrific commentator, and it's wonderful that Emmanuelle has joined civil law recently, well, about a year ago. Recently, sort of the black hole of COVID, we've kind of fallen into it, never to emerge. But we're so thrilled that Emmanuelle has joined us with a Canada Research Chair, and we look forward to working with you over many years to come, we hope, Emmanuelle. And finally to Frank, just such a fantastic presentation and so thoughtful in so many ways on all of these issues that we have to think through. I was tweeting that I think this is probably the greatest challenge, one of the greatest challenges we have, at least for the next 10 years or so, is how to figure out the governance of health-related AI and AI in general. But for me, of course, I'm mostly motivated about health-related AI, and I was getting so excited in the chat I couldn't stop writing. It's probably just as good as well you didn't see all that, Frank. So half of Florian, Atu, so we really appreciate you all being here. Florian, is there anything you wanted to add? No? Okay.
No, that's perfect. Thank you, everybody. Merci tout le monde.
Thank you. Merci beaucoup. À bientôt.